I'm Dr. Michael DeTola.
And I'm Megan Strong.
A New Jersey dentist listens to this show quite closely, possibly with headphones, and writes in to correct me and my pronunciation.
And if you catch your kid chewing on crayons, then we might have the right toothpaste for you.
And a British girl undergoes orthognathic surgery and goes from Leno-esque to lovely. These, of course, are technical terms. That and more on today's Chairside Live. Hello and welcome to episode I Can't Drive 55 of Chairside Live. Megan, how are you?
I'm doing well, and I can drive. How are you doing?
Can you drive 55?
I don't even know what that means.
Oh, you don't? An old Sammy Hagar song? I knew you were too young for that. It was a song about a man, a middle-aged man with long, bleached-out blonde hair who would go on to form his own tequila company, complaining that he had a hard time staying under the speed limit because he was so cool and had such a fast car.
Wow.
Have you had a speeding ticket?
Yeah,
Yeah?
but just one. Just
one?
one.
That's
Let's
not
not
bad.
talk about my accident record, but just one on the speeding ticket.
That's true.
How about you?
You drive like you ride a mountain bike, and it is off the sides of things and into other people. I've had way too many speeding tickets to even talk about. I'm surprised I'm allowed to drive in California. We've got a really interesting case of the week for you today. I could try to describe it, but I'm not sure I'd be able to do it justice. So, in fact, let's go ahead and take a look at that now. I was walking through the all-ceramic department the other day, and I noticed a case that utilizes a different kind of prep guide, one that the all-ceramic department started doing for me recently, and I don't think we've shared it before, so I just wanted to show it to you so you could see how it worked. This is the old bridge in the patient's mouth, and you can see it's not, just from the looks of it here, you can tell that it's not particularly aesthetic, most likely. I don't have photographs of it, but you can just kind of see, not a lot of lingual anatomy, pretty thick, kind of facially prominent as we look at it. And so the doctor took that off and then went in and cleaned up the preps and probably cleaned them up a lot. I'm guessing the preps did not look that good underneath that bridge. And felt like he was getting close, but still felt like they were out too far to the facial. Nice kind of 2-3 plane reduction. And rather than, and you can see though, we still have this one really coming out to the facial. And you know what? We may or may not be able to deal with that a little bit more, but he sent the case in. He impressed it at this point and sent it in. And we noticed a couple undercuts that we had on some of these teeth as we went in to design it. After we scanned it and brought it into the digital environment, it alerted us to the fact that we had some undercuts. And so we called the doctor about the undercuts, and as we were talking, mentioned to him, about the facial aspect. Do you think we could prep it anymore? And he said, yeah, there's definitely still some room to be prepped. I just wasn't sure if it needed it or how much to do. And I like when doctors say that because some of these cases are difficult to determine when you're done preparing a tooth. I've got my technician who I work with. There's a couple of them here in the laboratory. And almost without fail, when I'm prepping a case, they will walk in and I'll say to them, am I done? And they'll look at the preps and they'll say, oh, maybe round this off a little bit, or can we bring this back just a little bit to the facial, whatever it might be. And then they say, yes, now we're done. And it's a great way to be able to make sure that you get really good results because technicians, they're able to look at preps, and for the most part, I think they can visualize the final restorations in place better than we can as dentists. And so we look at it, and I think we judge reduction in our own minds by where the tooth was originally, or the old bridge was originally. And I think they look at it in relation to building onto it and making a final restoration, whereas we look at it in a more kind of destructive way, if you will, or a subtractive way, I should say, going from a full contour tooth back to the preparation. So I love having the technician take a look at it. So in this case, we looked at it and said, well, there are some undercuts. Let us help you out with that. So we're going to make you could either do two things. You could do a reduction coping, which don't really work very well on anterior teeth. Reduction copings work much better when you've got one area like a cusp tip. Usually it's a lingual cusp tip on a molar that's hasn't been reduced enough, so we're going to put a reduction coping over that. The little cusp tip will stick out of it and we'll flatten it off until it's even with the reduction coping. That works great. On anterior teeth, though, these longer teeth, unless it's just an incisal edge, we're going to go with a suck-down prep guide. In fact, with the undercuts that we have here, since we're going to be prepping axial surfaces, that's almost impossible to do with a reduction coping, as are the facial surfaces of those teeth, to try to do that with a reduction coping. It's just it won't sit on there well. So So to be able to do a thermoform splint, we're going to have to prepare the teeth the way we want them anyway. We're going to have to eliminate the undercuts. We're going to have to do more facial reduction, a little on the lingual. And so we have our prep guide, but it's always been my feeling that to simply mark where we prepared here and send this to the doctor, that's great. I mean, we can try to follow that in the mouth, but we never know exactly when we have prepped enough off to match what the technician did on the tooth, on the model, to make these preps perfect. So we used to do a prep guide, a thermoform prep guide that would fit over all these teeth, but again, it was difficult to tell exactly where it was. So the manager of the all-ceramic department wanted to take a more segmented approach, which I thought was a good idea. So we're going to do just tooth number 6 at this point. So this snaps onto the unprepared teeth next to it. And now this is going to fit down right over tooth number 6. So really all we're doing here is analyzing this one tooth. So we can look at the red reduction that's on here and go in and prep it by hand using a football burr, for example, on the lingual and whatever you want to use. I'm an 856-025 guy here on the facial. And we keep trying this on until this seats by itself and the tooth should fit nice inside like that. And you'll see that it's down all the way on the adjacent unprepared teeth as well, and then you know you're done on number 6. So this is a way, kind of like one of the great things about a reduction coping is it allows you to work on teeth individually. Most of the time for a thermoform splint, we would just do it all the way across like we've typically done for biotemps. You've seen me do that. And that's a little more difficult to try to judge all those teeth at the same time. So we did it for tooth number 6, which was nice. Now let's do it over here for tooth number 10. So we're going to put this on. We're going to do a little cross arch stabilization here just to help that stay on. And again, you can see here it's in perfect contact with that. And we'll roll this over. And again, you can see it's in contact, but you can see where we've reduced in red to get rid of the undercuts and where we've reduced on the facial so that it's not so prominent as it once was. And so the dentist, after doing number 6, would come over here and do number 10 until this fit down all the way. And so if the tooth is a little bit moist as you try this on, you can see it doesn't have this dry look. It's got kind of a wet patch. The water gets on there and it causes this wet patch where the light doesn't go through to the tooth anymore. It starts to look opaque in that area, and you know that's where you need to remove a little more. I've seen dentists who will take these and spray some of that green occlude powder on the inside and then try it back down on the prep to transfer that onto the prep to show them where they need to reduce more. I've seen dentists take these and prep a little hole with a like an 1/8 round burr here, so when they put it on they can kind of see, you know, where the tooth is a little bit better in relation to this. It all kind of depends what you want. The bigger thing here is that we're doing this segmentally. So we did number 6 first, then number 10. And at the very end, now we can go ahead and do the overall one. This is the one we used to use right off the bat. Now we're going to use this at the very end because we know tooth number 6 and tooth number 10 are where they are supposed to be because of the individual ones that we did. So now if this isn't seating, it's got to be tooth number 7. And so by the time tooth number 7 gets prepped, this will sit down and seat completely over all 3 of these preparations, and then the doctor knows that he has in fact done exactly the same thing in the mouth, or very close, or as close as we can hope to get between what the technician did on the model and what the doctor has done in the mouth. And now with this elimination of the interproximal undercuts and the additional facial reduction that we got, the dentist and the patient stand a good chance of getting a bridge back that looks a whole heck of a lot better than this kind of horse tooth bridge that we had before, kind of this monoblock looking thing. And so this is going to be sent back to the doctor, all 3 of those stents with some directions on how to prep that, and he's going to try to get it as close as he can to this, and then take another impression. Of course, we will make it from, you know, however far he gets. This doesn't take into account where the pulp of the tooth is, and so he might, you know, see this starting to blush or turn pink as he gets too close and stop before he gets to this point. But this is just kind of telling him what the ideal is. If you're able to do this, this is what the ideal is. If it's somewhat short of that, we can still work with that. But again, we're going to be using these segmented prep guides.
Now let's go to a segment we call Viewer Mail. This week's viewer mail comes to us from Dr. Gil Amthor from Blythe, California, and he writes, "Dear Dr. Datola, I was at one of your programs recently where you said that the 2 weeks most of us wait between prepping a crown and seating a crown was pretty much arbitrary and not based on many logical reasons. What do you think the ideal time frame would be between prepping a crown and cementing the crown? Thank you, Dr. Gill.
Well, Gil, that's a very good question, and I remember meeting you at that lecture, and this must have been one of the rare segments where you were awake during the lecture, and I'm glad you heard that because I do feel like it's pretty arbitrary. And when I first started practicing, I came into a practice where it was always 2 weeks between when we would prep and when we'd cement. And I talked to a lot of dentists who feel the same way, and we know in the lab we keep cases here for 5 working days, and most dentists tell us that they cement it after it's been 2 weeks. I can't find any scientific evidence for it when I go online and look to search to see if somebody did a study saying that pulpal tissues calm down or anything good happens. In fact, in my opinion, all we're doing is setting ourselves up for a little bit of failure. And the way I learned that was kind of by mistake. It was by practicing here in the laboratory. And oftentimes, especially starting in 2007 with Emax and in 2009 with Bruxer, they were bringing crowns back to me a day or two after we had prepped them. And since most of my patients are actually in the building here where we all work, it was very easy to grab them and have them come over and take off the temporary and just put the crown into place. And what I began to notice was crowns that we were putting in after 2 days instead of 2 weeks needed far less proximal adjustments to the contacts and far less bite adjustments as well. And it took a while before I started to notice, boy, this is really kind of a trend that I see happening here. And it makes sense. You know, our dental assistants who are making our temporaries are trying to polish these temporaries, make them nice and smooth so the tongue's not going to be bothered. And when they do that, it's easy to polish away an occlusal contact, polish away a mesial or distal contact, and start to get shifting of the adjacent teeth or the opposing tooth. So you would expect, and we've all experienced, that if a temporary stays in place for 6 months, kind of an extreme, that you might even have to remake the crown because there's been so much super eruption from the temporary being worn away. So if 6 months we know is far too long, it stands to reason that if 2 weeks is acceptable, that 2 days might be even better. And I think by extension we know, or at least I've proven to myself, that same-day dentistry via a CEREC unit, for example, where you prep the tooth and you're cementing the permanent restoration, needs even less adjustments than that 2-day crown. And plus, we don't have the temporary on for 2 days while the patient's going through life. There's always the chance that we're going to have some kind of bacterial leakage underneath the temporary, or it could fall off. And we have the chance that the teeth around it are going to move. Frankly, I tend to look at the time when the patient has the temporary on as nothing good can happen, and there's potentially bad things that can happen as well. So the shorter that temporization time is, the better. Ideally, we'd all be doing it same day, but we're not quite there yet. Short of that, though, I'd like to see a movement to go from 2-week dentistry to 2- or 3-day dentistry. On our end, with these monolithic materials like Emax and Bruxer, we can pull that off. The thing slowing it down is the incoming impression, for one thing. So if we were able to get more digital impressions, we could do that. And if we were able to get it back, it's just the overnight getting it back. If we get it early in the morning, we can design it then. We can mill it, goes in the oven overnight, and it's ready to be shipped out the next day. So 3 days are a reality. We're just going to have to change some things in the lab from how they flow right now. But it's a great question, and I really think we're going to see a shrinking of that time because it doesn't make a lot of sense just to leave it at 2 weeks just because that's how it's always been. It's just a tradition that it's kind of like the, come to the dentist every 6 months to get your teeth cleaned. There's not a lot of scientific research. That comes from an old toothpaste commercial. So, Gil, thank you very much for being the letter of the week. I'm going to send...
Not quite yet. We've got another bonus viewer mail that might win the prize here.
Well, I like Dr. Amthor's question. He'll get it for sure.
Okay.
There might be 2 today.
There might be 2. So
Gil, you get the limited edition Chairside Live water bottle. That smell, I'm told, goes away after the first 100 uses. And we have the Bruxer adjustment and polishing kit. I know Dr. Amthor does a lot of Bruxer restorations and enjoys them. So thank you for that question. Go ahead, read your second contestant.
All right. This one comes to us from Doug Peterson from Little Silver, New Jersey. And he writes, Dear Dr. Dottola, this could be the shortest viewer mail ever. And I hope you don't take too much offense to it. But you continually pronounce the word height as height with a TH on the end, as in the height of contour. Please stop this madness. Thank you. And again, no offense intended, just trying to help out because Chairside Life has been such a help to me.
I love, you always know when somebody says, no offense intended, that somebody's about to get offended.
Completely offended, right? Yes.
That's interesting. I have a hard time believing that I do that, that I would just randomly, who throws THs onto the end of words? Isn't that a diphthong? And why?
You do.
Height. Let me survey the crew. Do I do that?
I've never noticed.
Probably. Yeah, okay. Well, everybody who's on the payroll says I don't do it. I went back and looked, and he's correct.
Yeah.
I do that, Doug, and thank you. I appreciate the constructive criticism. I really do, and I'd love nothing more, actually, than to come by your practice and watch you work for a little bit and see what you might happen to do, any little peccadillos you might have. But that was good. Thank you for bringing that up, Doug. And because of that, you are going to win our Chairside Live, our coffee mug.
Wonderful.
And that's fantastic. James, I'm going to go ahead and hand this to you now. Oh, God! Oh, Doug! Oh, if only that hadn't fallen from such a great height. No, we'll save you a real one, Doug. I'm just kidding.
Oh, goodness.
I know. It must be very annoying to hear me say that, and I promise to try to stop. Somebody shock me if I say it again.
You got it.
All right, thank you very much. You have any news?
I do.
Okay.
It can be difficult to get young kids to brush their teeth, but a new toothpaste from Sunstar Americas and Crayola might make it a little easier. Crayola's Squeeze-A-Color toothpaste comes in a variety pack of child-friendly tubes with 3 colors and flavors: Blueberry Burst, Jazzy Apple, and Melon Blast. Kids can get creative by mixing and matching colors and flavors. The fluoride toothpaste is safe for children's ages 2 and older and will cost about $4 to $5. You can look for it in stores and online at www.gumbrand.com this August.
What do you think about that?
Well, as a kid, I was trying to think about it. I don't think that I really had a hard time. You know, my parents didn't have a hard time getting me to brush my teeth. Right. Give me a princess toothbrush and I'm in.
Right.
That was all it really took. But I do think, if it gets kids to brush their teeth, then have at it. It's pretty cool.
Well, if it's going to be, colored like fruits, why not just tie it to the fruit? I just think it's weird that it's like crayon colors, because I don't think that, isn't it making kids want to put crayons in their mouth once they're done brushing?
That is a good
And chew
point.
on crayons. I don't know how Crayola got involved. I ate a burnt orange crayon when I was a kid, too.
That explains a lot.
That and a raw umber.
What is that?
Just a color that for some reason, the word always stuck in my mind, raw, the 2 words raw, umber. I just don't know why they don't associate it with the actual fruit, so that kids might want to eat fruit afterwards.
Yeah, and this actually, I'm just wondering if this is going to be as successful as Heinz attempt to make their ketchup into like the crayon squeezable art. Did you ever see those, like the purple ketchup, the orange ketchup?
No, I missed out on that.
Yeah, it didn't do well. It flopped pretty big. So, but maybe this'll work out better. But it might actually, tempt kids to then go to the crayon box and start eating every color in the rainbow.
And it just seems like the next step, of course, is going to be Crayola Navajo White, and kids are going to start bleaching their teeth with the white Crayola toothpaste.
Possibly.
And we're going to start these little aesthetic monsters, even younger than they are now.
Sure.
Anything else?
Yes. I always felt like I had the wrong face. That's what 24-year-old Sophie Yates from London said before she underwent orthognathic surgery in 2009. She was bullied about her extreme underbite since the age of 10 and even had braces for 10 years and decided the surgery would be her best option. Sophie had 4 teeth removed and her jaw broken, fitted with metal plates, and then realigned. After a month of drinking through a straw and 7 months for the swelling to subside, Sophie loves her new face but is barely recognized by her friends and loved ones. She says it has improved her confidence and made her happier.
Yeah, that's one of those things that I was happy to see those pictures when you look at the before picture, like this first one.
Sure.
You can see that chin, that Jay Leno-esque chin, and that would be hard for a guy, but it's exponentially harder for a girl. Can you imagine being in high school when the kids are just brutal and kind of having that chin?
Oh gosh, it would be awful. And she even said, apart from the bullying that she unfortunately was a victim of, it was uncomfortable, and she said that it was more comfortable to keep her mouth open all the time because just the way to hold her jaw together, it was uncomfortable for her. So it's painful not only physically but also the emotional aspect of it. So
and there's really as we look at this second one, I guess I'm hoping this is Halloween,
right.
But this is one condition that there's no real orthodontic treatment for besides surgery. Orthognathic surgery is the only way to deal with something like this. And then when we look at this after picture, this looks like her high school graduation. I mean, look at that.
Believable.
Look at it. You put that up next to the Wonder Woman picture, if we put those two up together, and that's just truly amazing. That is night and day.
It doesn't even look like the same person.
It doesn't. And we talk sometimes about porcelain veneers, you know, improving somebody's self-esteem or something aesthetic. But look at that. I mean, it's absolutely incredible. And the problem is there's a bias. We see this last picture of her after too, and it was interesting to hear her comment that her friends and family don't even recognize her. That probably makes her very happy. You know, that's something that usually you wouldn't want to hear from friends and family, but she's probably pumped up about that. You might be a little young for this, but do you remember Beavis and Butthead? I don't know if you ever saw them, but they took the two stupidest guys on the planet, and to make sure that you knew this or to reinforce, you know, the stereotypes, one of them. Beavis, had this, was a class 3 and had that that same underbite. And then Butthead had a really gummy smile. You know, he had this super high smile on it. I always thought it was interesting because besides their bad metal band T-shirts and bad haircuts, the only way that you could tell these guys were a little off was one of them had, you know, a gummy smile and the other one was a class 3. And it was like, it makes you stop and think, wow, these dental conditions really, unfortunately, almost kind of send a message, or at least there's a stereotype, you know, about what people think when they see something like that. So to see something like that at the hands of an oral surgeon, a dentist, and orthodontist, we're probably all involved as a team effort there. That is absolutely amazing because that is a life that has been permanently changed for the better.
Forever. That is incredible.
Good stuff. Fantastic. Love to see that. All right. That about wraps it up for this edition of Chairside Live. On behalf of myself, Megan, everybody here at the lab, and the Chairside Live crew, I want to thank you for your time and your continued commitment to quality dentistry.
We'll see you next time.
How are you set on news?
What?
How are you set on news?
I thought, that was so weird.
News?
Yes.
Got news?
Yeah, I do.
Any chance you got a couple news stories you can share with us?
Are you just going through puberty?
And now, Megan and the news.
Why are your eyes open so wide?
Sorry to throw you off.
Okay, it worked.
You have any news for us?
I do.
Okay.
He said okay quietly under his breath.
How dare he say okay?
Gosh. No, if you would have heard it.